Good afternoon, wherever you are in the world, and welcome. It is the THCB Gang for May the 21st, back at our regular Thursday time slot. Now, I'm no longer pontificating to the folks at Columbia Business School, which is why we moved last week's. And a good selection of the gang with a special guest on today. Really looking forward to this. Who have we got? Well, you can read it off there. Kim Billard, marketing whiz, now regular THCB contributor, and way back in his youth, e-marketing guy at a big health plan. Patient advocate extraordinaire and board certified, Grace Cordovano, enlightening results many places on Twitter. Rograd Sarab Jar, fulfilling our quota for the English sounding Asian doctor from Philadelphia. We now have another one who comes from the gang occasionally, but not on today. Brian Kleber from Charlotte, North Carolina. Guy who knows about employers and the healthcare system with us. I might join this few. Vince Karatis from the wilds of Idaho, and Deb McGraw, a health privacy, former government bureaucrat and now crack entrepreneur, still pontificating about the University of Maryland in the background there as if they won the NCAA hoops at any stage in their careers ever. And our special guest, Rajesh Ricciardi, I said that correctly, or the last time I interviewed right, didn't, at Rajesh, who is now, like Devon, a thrusting entrepreneur, but used to be the head of consumer activity at RNC, while Devon was running the Office of Civil Rights. So we have a couple of former government bureaucrats on from the DC area. With that, we're going to go live and ask them what they saw and we're interested about in the last week. We're a big gang today. We're one away from Brady Bunch, but it'll be fun next week. So let's start up. It's been yet another hell of a week. I mean, they're all like this, but it looks like maybe we're sort of going back to normalcy. I don't know. We'll see. So let me start up, and I'll just pick Brian because you're in the middle of my screen, and say, what do you see in the last week that you found interesting and different?
Omada acquired Ficea. Bizarra. So they raised $57 million and they paid $30 million for Ficea. I've looked on their site. I can't figure out whether they have anything that is of note, but what you've got is the development of multimodality risk management functions. It's going to be more of that.
More of that. All right. Grace, last week, what's piqued your interest?
Oh, this week we're seeing that testing is a hot mess express. A lot of concerning stuff coming out on testing and how we're reporting testing and how it's even humanely possible that we're reporting and lumping all these tests together. Not sure how that's possible or what's going on here. We need a point person to organize this and lay it out. Somebody, please.
Well, Anish Koka wrote a great piece about it on THCB, and at the end of the piece, which I barely understood, I came to the conclusion it was a hot mess express too. I didn't have that expression, but it's a great one. All right. Devon, what do you see in the last week? Piqued your interest?
Well, it was kind of quiet, but Atul Gawande leaving Haven in order to focus more on COVID-19 related issues. And I'm sort of wondering, I'm glad we have Brian on, sort of what this means for the hotly anticipated or greatly anticipated Haven and what they would do to change healthcare. I think people were looking at that initiative as somewhat groundbreaking, and without Gawande's leadership at the top, I sort of wonder where that's headed now.
Interesting. Sarab, what do you see in the last week? What are you focusing on?
Yeah, I'm not sure about the last week. It seems like a very long week, but I saw something in the last 1 hour that was very interesting, which was a report in the NPR that the number of organ donors has gone down because the number of road fatalities has gone down because there's less economic activity. So it's a nice kind of karmic circle that we're in, that you need a certain degree of economic activity to keep people alive. And if people don't die, that can be quite selfish in society, and others will suffer because people are living longer. It's just nicely ties everything up in this death economic type of passing out what causes what and where the trade-off is. It's very complex.
There's actually a Monty Python sketch about that. There are two there's the live organ donation sketch, and there's another one about where there aren't enough accidents and they have to start putting people in, merging people into chairs and stuff. I have to find that one back in the archives. All right, Vince.
Yeah, the issue I would like to put on the table for discussion is contact tracing, a process that's going to be necessary really if we're going to contain the virus, and more accurately, the lack of contact tracing. So yesterday, Google and Apple revealed the final details of their, I'm using my words carefully, exposure notification app platform is how I would describe it. They're not building the apps, but they are building the platform for it. And as well-intentioned as I think Google and Apple are, I think this thing is headed for oblivion. They are going to have huge challenges getting critical mass, and they really haven't paid a lot of attention to who I think is a key partner here is the state and local public health agencies. So I think that there's going to be a lot of questions. As part of their press release yesterday, they did announce, though, that 22 countries have requested the API, and 3 states, Alabama, South Carolina, and North Dakota, are working with Apple. So I've got to think they're somewhat disappointed by the lack of state representation. More broadly, the issue I think is that states are just woefully unprepared and underfunded, and we can go into that a little bit later. So that's the issue I'd like to put on the table. Thanks. Yeah. Thanks, Matthew.
Back in the testing world and back in the how are we going to figure out what life's going to be like after we go back to normal, whatever normal looks like. Kim, what have you seen in the last week that, or in the last hour, or some combination of the above?
There was a report that came out that like 90% of deaths of physicians in the UK were minority backgrounds, and it just underscored what a particularly devastating impact this is having on minority populations. We've known about the mortality rates in the US and everywhere else. Minorities are more likely to be jobless as a result of this. Minority businesses are less likely to get PPP loans and are going to go bankrupt. So as bad as this is for everybody, it's particularly devastating for minority populations. And gosh, you just don't know how we're going to recover from this.
Yeah, sobering stuff. Ajay, welcome. Tell us what you've seen in the last week, and then we'll bug you more about what you're up to more generally.
Yeah, so a couple of interesting pieces of news related to telehealth. One is that Blue Cross Blue Shield of Tennessee decided to permanently cover payment for telehealth. So that's kind of a big deal. There's been a lot of, as you know, short-term, immediate sort of emergency coverage during COVID-19. But this is the first I've seen where you've had a payer saying like, it's staying that way, definitely. So there's that. And then at the same time, there's some interesting news about consumers and telehealth. And in particular in Forbes, there was an article about how pre-COVID, only about 25% of people had used telehealth. And now, of course, it's much higher. But the thing that particularly interested me is that 33% would actually leave their provider for a provider who offers telehealth.
That's fascinating. I was literally, so I spent the last 2 hours on although it could have been anywhere, it was Health 2.0 Egypt. You may not know there was a Health 2.0 Egypt. They had a session which Ali Parsley, who's the somewhat controversial, very controversial for our little space, CEO of Babylon Health, was on, and he was talking a lot about Babylon, which not only has an AI diagnostic tool, also owns a bunch of primary care clinics, GP clinics. They're not under the state, under the NHS in the UK. And we got in this discussion about how do you put those two things together, and a lot of people left their GPs to move GP to his GP practices, and that's been very controversial in the UK anyway. So I mean, it's a good point. My thing I've been watching this week, and I've been tweeting about a little bit, is I've been still watching the stock prices of all these relatively recently IPO'd companies in the sort of health tech space. And the one that blows my mind is that about a week ago, One Medical announced their results, and as you might expect, this was a company that runs high-end physician clinics in New York, San Francisco, and a bunch of other cities. They charge sort of at the top of their range, at the top of the range for the fees they charge. They've been getting that money for a bunch of reasons that are a little unclear if you look at their data. And they've seen a collapse in the in-office visit. They switched to much of the telehealth. They were getting paid less for the telehealth. They came out saying that their earnings, their revenue was going to be down and their losses were going to go up because of this over the next quarter. And their stock prices doubled. So you explain that one to me. This maybe we're back in Silicon Valley. The more money you lose, the higher your stock price goes. I don't know. As you know, and this Brian mentioned, Armada raising some money and buying, going across their platform. Teladoc stock's gone up a lot in the recent, off a little bit the last few days, gone up a lot in recent weeks. And American Wellness, big competitor, Amwell as they're called now, just raised another 250 in the private capital markets from current investors. So, the kind of interesting dichotomy between, which is, between people who are doing well, the Zoom stock price phenomenon, the Amazon stock price phenomenon is reflecting a lot of the world, right? But it's not entirely clear what's going to happen, I think, and perhaps we can get into this in the first sort of round of discussions. Not entirely clear what's happening between the kind of the physical world where we've been in and the world that we're in now and going to stay in or whatever. So that's perhaps a way of opening the conversation. And a lot of that's got to do with, the patient experience. So Rajesh, you were the boss man at ONC around consumer experience for technology for a couple of years. Now you're at a company, and you've been consulting this area for many years. Now you're at a company called Carium, which I guess most of us don't know anything about. I'll rephrase that. I know nothing about, although I've talked to you a bit about it. So tell us a little bit about what you're up to now and what you're seeing regarding the kind of current set of consumer experiences with healthcare. And that's what Grace comment.
So Carium is a virtual health company. It's a platform for virtual care, which Vince will be happy to hear after all these years of talking about platforms. Essentially what it does is it allows consumers to use a smartphone, and providers can use any kind of web interface to stay connected all those times when you're outside of the clinic, which nowadays is pretty much all the time. So basically it lets you not only connect to your provider, which a lot of services do, but also share data so that you can have a full array of information about your daily kind of, it depends what kind of condition you're tracking, but you can share data about, let's say, your heart rate, your weight, your mood, all these kinds of things with your provider, and they can be looking at it at a distance and intervening whenever they think appropriate. So we've got all those pieces plus some kind of virtual nudges and ways to encourage you to change behavior, really drawing on behavior change science. So in a big picture, it is a way to, it's a platform for connected care that really empowers patients to work with their providers in the course of daily life.
Does it work?
Does it work? Yeah, it seems to be working really well.
I'm asking a legitimate question. Is there solid data showing that if you just add this, that outcomes get better, costs drop?
Yeah, so that's, as you know, a complicated question. It does enhance patient experience, patient relationships. Some patients have seen market improvements in, health measures, but it's hard to isolate exactly what's the platform and exactly how it's married with our partners. So to be clear, we're a little bit different from some companies in that we partner with provider organizations and they actually use a care team member who's in-house. It's like DIY. They can use their own care team on steroids to reach out rather than outsourcing and hiring a company like, for instance, Livongo or something like that, that brings their own folks to provide care. We enable our partners.
Right.
Yeah, that's interesting because that's a sort of a typical problem for a new company in this space. You've got these cool tools, but do you build it yourself or do you try to figure out who in the existing system wants to use them?
Right.
And I think so. Brian, let me ask you the broader question about that. You've been involved in this from all sides, from the employer side. You were in a clinic at one point. What do you think you can fix the old with cool new stuff like Rajesh's got now, or do you think you have to blow up the old and build the new?
Well, I think that there are a slew of really interesting companies that have emerged that are driven by people who are passionate and mission driven. They're data and evidence driven, and they have huge expertise in some niche that's important. And they have deconstructed an existing problem and come up with an entirely different solution than everybody else has. and then they've tinkered with it over time, and they get outrageously great results. There are only a few of them that I've found, maybe 25, but they're in all kinds of niches. They're in musculoskeletal and cardiometabolic and cancer management and imaging and drug management and large claims resolution and on and on. But those are replacement paradigms.
So
Right.
let me ask you and then go back to Rajesh for a second on this topic. So, we had the deal this week where one of the big sort of starting with diabetes, but becoming a platform for chronic care management, Amada bought a musculoskeletal company. There's a bunch of others that are doing well. There are rumors flying around about Livongo buying one too, etc. Maybe they're made up by Jessica DaMassa and me, but they're rumors anyway. Do you tell me about the musculoskeletal company that you like or seen or we're talking about, and tell me how they're doing it, because there's a lot in that space going on. Maybe you can isolate it from the rest of the world, but tell me a bit more about that.
You're aiming at me, right?
Yeah, I'm aiming at you. You said you liked a musculoskeletal company, or one that's doing. What do they do? Who are they? What do they do?
Well, the best musculoskeletal company that I know of, and that I have a lot of data on, they've got over 1 million patient encounters, is out of Tallahassee. It's called Integrated Musculoskeletal Care, and it has worked at Michelin, for example, for 9 years. And the data, there's a tremendous amount of data on them, and it shows unequivocally that they get better health outcomes, pain reduction, range of motion, activities of daily living in half the recovery time and at half the cost of conventional orthopedics. So if you're talking about an area that is functionally 25-26% of total spend, they'll make a 25% reduction in cost guarantee on MSK for the patients they touch. That translates to a 4 to 6% reduction in total spend, or more likely, beyond the guarantee, an 8 to 12% reduction in total spend. That's huge. Those are huge numbers.
And they do that by basically getting people into physical therapy and avoiding back surgery, or what's the trick?
Their work is based on a subdiscipline of physical therapy called mechanical diagnosis and therapy. Comes out of New Zealand. It's very accurate. It's got a very accurate diagnostic methodology. And they've evolved it way beyond, so that it's become a new musculoskeletal management paradigm. It's a very interesting thing. But I've seen this in a lot of areas as well.
And Rajesh, when you talk about you guys, you're building a platform for behavior change. Everyone talks about diabetes and musculoskeletal. Where are you guys focusing? And then if you get something like that, do you build that yourselves? Do you bring something like that in? What's the sort of the play? And what are your customers? There's the second part of this, right? Because how are your customers getting paid, and do they care about it? Because many of us on the phone will tell you from any part.
So we've deliberately chosen not to go super deep in a particular condition area, but to maximize the platform, because in our experience, we're able to come into a health system in one area and then spread to another area and another area and another area. And it's a value to them to have one consistent system that they can use, instead of having to sort of jigger together a whole lot of different apps and tools and make it all work in the back end. So that is our play. That being said, sometimes we have a partner who wants to go super deep in some specialized area that we don't have, and we're able to partner with companies who do provide that service. So, but we've maximized in general for that sort of like, what are the generally applicable types of functions that a health system needs in order to care well for patients outside of the system, almost regardless of particular condition.
Great. Now I want you to take off your, crass entrepreneur selling hard hat and go back to your, consumer advocate, surveyor of the system hat. We've talked forever, and you've talked a lot about this, and the idea about consumers getting involved. Obviously, you've got also on the screen a couple of the real leaders in getting consumers access to their data. Actually, it's all the women here on the phone who've done useful stuff. All the men who are sitting around talking about it.
Oh, you data blocking men.
Yeah, exactly. But where, if you were to, and I did some work with you about this way back when we were at ONC back in 2013, 2014. If you were to say, have we got anywhere? How are we doing? And so this journey towards a better consumer experience as a whole.
We broadly, I think we are moving forward slowly, but we're not anywhere near where we need to be as a country. I think it's super exciting that the policies that I was working on and their extension at ONC in terms of API access to records have continued to progress in a good direction. I think that most healthcare providers are aware of the importance of consumerism and the power that consumers have to walk with their feet. And that's going to be increasingly the case now, sort of during, I don't know where we are, the new normal that we've started, COVID time, as there are all these, like, care as normal is no longer available. So I think that that's definitely pushed change, certainly in the area of virtual health. But do we have a fully sort of consumer-centric, patient-empowered universe? No. For one thing, it's hard still for many patients to get access to their data. But more importantly, even, is to have tools and experiences designed around them that focus on their priorities and that make life easier from their perspective. And I think for many years, the healthcare system has built tools sort of from the inside of the system out to consumers. And we need to be shifting that and going the other way, saying most of health happens during the course of somebody's life. How can you build tools that work for that individual, design around that, and then help others to support them through that, through healthcare systems and other modes?
So if I was to take the Brian Clapper view on this, it would be that people, providers and organizations have always been paid to do what they do, which is to do more and more unnecessary stuff, and haven't been rewarded for helping people out there in the community or wherever they are living their lives, do the right thing to change their behavior and all that kind of stuff. So I'm aping your remarks, Brian, but I know you'd agree with me. So yeah. The problem here has been that, of course, that we've paid people to do the wrong stuff forever. We won't mention the RUC, because Brian sued them at one point, didn't get very far, but it's true, right? We have all these we have this massive establishment that's based on the way we pay people. If you're going to work for the incumbents or the current system rather than try to blow them up and start again, are you finding that they're getting paid the right way and they care about this, or is this a nice to have?
Well, I will say this. We have had the most success. One of the ways that we're different from many other folks in this area is that we're not interested in just bolting on to the existing system. And we see ourselves as helping as partners on the path toward value-based care and patient empowerment and centricity. And all of that is baked into our design and baked into our ethos. And so the partners that we've resonated with and the partners we've done the best work with are on that trajectory. We're not even trying to sell to those folks who, and I'm thinking pre-COVID now, we're just kind of more business as usual, those kind of like continue fee for service forever kind of folks. I totally understand that in the current environment, many healthcare providers are under a lot of financial stress, and it's hard to make that flip in this context. I understand it's a complicated situation. We can add value to folks who are in a fee-for-service world, in part by really boosting consumer loyalty through that relationship to the provider and a really excellent experience. But ultimately, I mean, personally, it's not really my interest to keep strengthening the status quo, but rather to evolve it and push it toward this world that we've talked about, and I've talked about with others of you on this call for many years.
Hey, Matthew, can I hop in? Yeah. So, Lygia, you raise an interesting point, and I'd like to raise a question really for everyone to think about. It's, will this migration, will the COVID crisis move us toward or away from the value-based care and value-based payments? I've heard it argued both ways. I think personally it'll move us closer toward it, because I think you see what happens with fee for service, and the volume goes away, your revenue dries up. But I'm curious how others would see that.
I do have a comment. There's a lot of reports about doctors asking, where are my common typical patients? Where are my strokes, my heart attacks, my usual triage work?
Mhm.
And from what I'm seeing from the patient and care partner perspective, people, of course, are afraid and avoiding the clinic unless necessary, but now they can contact someone for support. I'll give you an example, and I'm just wondering if we're going to see improvement in some disease states and some comorbidities because of the fact that people are so afraid and they're avoiding. Are they in contact with their telehealth team? I'm seeing this with multiple family members, colleagues, friends, and I'm in, again, hotspot area. We've been seeing it with my mom. Language barrier, simple flip phone, just started using GIFs on Facebook. Okay, bare minimum of technology.
That's why Facebook paid $4 million for Giphy. Go on. It was your mother's
now,
point.
a few, just recently we had that experience where mom went and just missed the emergency room with stroke symptoms. She's been doing wonderful. And now anytime a question, and I can't go to her house. I haven't been in her house for 9 weeks, which is the longest ever. I'm her primary caregiver for everything. She now says, well, I have a question, Mom, how's your blood pressure? I'm just going to Zoom, Dr. So-and-so, her primary care, regularly contact him, regularly in contact with the cardiologist, regularly in contact with the oncologist. And she just does this proactively, where normally she would have, her follow-up in 3 months. And maybe that problem isn't there, or she'd adjust the medication herself, knowing that she can't get an appointment sooner. I think it's been great, actually, and things have stabilized. She has more contact, I think, with her care team than ever. And I'm just wondering if we're going to see reports later on data that we've collected, that we are going to see some improvements because of technology, like Gia, like what you're saying. We have so many reports of the uptick of telehealth. I would imagine there has to be some kind of positive here. Maybe this is a good thing that we're not seeing some people come to the emergency room. Maybe they've been able to somehow navigate this in a new way.
Rob, you look like you're either appalled or shocked or maybe agreeing. I don't know.
It's one of those discussions that have been going on even before COVID. The value-based care, just doing things that are of high value and not doing things that are low value. And the problem has been that it's often the low value stuff that gives the hospital the revenue in order sometimes to pursue the high value stuff. And when hospitals lose their revenue, it's not when they lose their revenue and they have to recalibrate, it's not always easy just saying, okay, let's now just do the high value stuff, not the low value stuff, because the distinctions are very gray between the two.
Right.
As time goes on, I think they're going to stick to the fee-for-service, at least in the short run, because they need to recuperate all the losses. So all the oncological patients that come back with frequent PET scans, you'll get them back to have frequent PET scans. Not with the view of filling the hospital, but the hospital won't discourage that. In fact, the hospital will encourage it, and we've already been told in radiology that prepare for the rebound effect in August and September, where we're going to be even busier because of the slack and the return of that. I think that's probably going to be the busiest time for us, actually, busier than ever before. So whilst a lot of people have realized that there are certain things of higher value, we've also lost certain things that you just simply don't have the discernment unless you come to the hospital. So the strokes, the myocardial infarction, they're not all, they're not all the highest grade of myocardial infarction. Some are things that you normally put off, and some people putting it off would say, okay, fine, and it turns out to be indigestion, but in a few it doesn't. And that's the kind of marginal type of stuff that we've lost because of COVID. And it's been a mixed blessing. It's led to some people that have allowed nature to take its course without the interference of doctors, which I think Voltaire said is what doctors do, just allow nature to take its course. And there are others in which nature took an unfortunate course.
Right. Devin, just want to come back to you. You've been looking at this from a variety of perspectives, but also with Citizen, out there looking for the pace of change around cancer patients getting access to their records and sort of their experience. We've got a lot of threads going here, but you can sort of summarize or give some comment?
Well, I mean, there's not a lot of value-based payment going on in the cancer space. I mean, there certainly are cancer care models, like the CMS has been working on a payment model related to cancer care, but there's not a huge amount of uptake. It's, it's one of those diseases where, the costs can be gigantic. And obviously there's a great interest in, sort of doing what you can where you've got a diagnosis of cancer where you can treat less intensively, but that's not going to be true for many people. And for most folks, they want to try to pursue whatever treatment is possible for them, obviously taking into account, just how intensive do they want to be? Do they want to, can they tolerate the side effect profile? What are their own goals with respect to treatment and all of that stuff? So it's sort of, we can talk about fee for service and value-based care. And I sort of tend to agree that the cost pressures are going to be so high on healthcare institutions, given the hits that they're taking with respect to COVID-19, that this could frankly set back pretty significantly the value-based care movement because providers are squeezed so tight. Folks may disagree, but cancer is sort of outside of that. And in terms of, sort of where we are with respect to how well patients can access their data, I mean, we talked about the scorecard on a prior THCB Gang episode. It looks like it's improving from our standpoint, and certainly some of the new regulations that will require greater, sort of more seamless plug-in kind of access for consumers will help. But it'll still be years before, someone with high intensity data needs, like a cancer patient, in order for them to seek the kind of care that's going to be of most use for them, is going to be, well beyond what will be available through those pipelines for some time to come. And so I think there'll still be challenges for people, because for far too long, we've sort of viewed the ability of patients to access their data as something that's, well, maybe not as important as the doctor's getting data, or it's okay to put that on a different timetable, or to delay that, until we get the providers to exchange data with each other, always playing second fiddle. And, I think that's going to become less and less. I mean, I don't know that it was ever morally justifiable to begin with, but I think from a business standpoint, that's going to be less and less justifiable over time.
Do you, on the just a particular issue that Grace raised about access to care and this, and Sarah mentioned, do you think that the delay of access to things like cancer surgery and chemotherapy, I mean, have there people been not able to get access to stuff they really need? Or do you think that,
Grace
probably are you seeing that impacted a lot in your work? Yeah,
no, for sure. Absolutely. I mean, people who were supposed to go into clinical treatment trials where the trial was just postponed.
Right.
Potentially indefinitely. They don't have any other options. I mean, Grace probably has more stories than that. And her example actually of people getting, potentially better care at home is terrific for the patients, not so good for the healthcare system, because those are dollars lost, right?
So I want to jump on the dollars lost part and bring Jane Kim into this, but there was a bunch of reports all out of Healthcare Dive, which had it like things like financial crisis at Sutter and the world falling apart at Mayo. And basically, if you read the report, the first thing was that the financial crisis was because they're in down, the cash they had in the stock market had gone down. At the end of the quarter, they were forced to mark to market that they were looking bad at the end of March. So it wasn't a real number from their operations. They were losing a bit. It was only the last part of March they've been losing money. And even the ones who were losing money in April, were doing kind of okay. And then the second thing was the government was sending them all a big fat check to make up for the amount they were losing in general. And the third thing was, if you panned out the fact of how much they were losing by a month against all their reserves and endowments, it would take them about 5 years to go out of business at the current rate for Sutter. And I think it was like 12 years for Mayo. So I mean, it was like I was having trouble seeing the thing that I mean, it's not fun to go in that kind of transition, but I'm having trouble seeing how drastic it was for those folks. But there are obviously areas of the country. There are individual clinicians, we haven't on a niche on this week, but physicians who have their own practice running on thin margins, and then safety net hospitals and hospitals who don't have the sort of the Mass General, the Mayo Clinic, reserves stashed away in the Cayman Islands, who are in trouble. But it seems to me that, the question is, are they going to be looking now for an alternative? Are they going to be doing what Sir says, well, we'll make it up on PET scans we're going to do in September and October, and we're going to start running that, the cardiac cath lab 24 hours a day, and we're going to make it up that way? Or are they going to be saying, maybe it's time to think about a different way of doing this and a different way of getting paid? Kim, you've been pontificating about how hospitals should do stuff for years. What do you think?
Well, I sort of to Vince's original question, I hate to say it, but I don't see that we're going to necessarily jump to anything better, because our reactions so far have been more knee-jerk than strategic. Telehealth, all these things we've done, except for Blue Cross of Tennessee, have really been temporary. We haven't said, these are good things to do, let's do them permanently. We're waiving.
Can I point out that the British government introduced income tax in 1915 as a temporary measure? Just to let you know.
Oops. We're waiving cost sharing for COVID, but not for heart attacks. And we're not really thinking through strategically, what's the bigger picture here? What can we really improve? So we're just doing what's in the short term necessary for this without really thinking through the longer term implications of it. So I'm not entirely optimistic that we're going to come out of this with a better built system, as opposed to sort of another jury rig on top of a jury rig system.
I think
To play devil's advocate here, going back to the last conversation about patients improving in some situations because of telehealth, could hospitals see further losses because they adopted telehealth? Because patients are avoiding going into the hospital?
Yes.
I mean, quite possibly, but on the other hand, there are some things you can't. So I go back to the One Medical earnings report, transcript, which I read because someone insulted me on Twitter about how little I knew about it. I haven't actually read the transcript. I'd read Dan O'Neill, who's sometimes on the THCB Gang. I'd read his version on Twitter about what it, but I actually read it. And they clearly said that they do a lot of stuff in the office, during office visit, which they charge a lot of money for, and they can't do it. There's like blood draws.
And they lose the facility fees.
Right. And then there's a whole mess about, the facility fees and other stuff in relation to other hospital practices. But there's a lot of strange stuff going on in the background there of how money gets moved around, which does go away. I'm just wondering if they yes, maybe the patient experience does improve, but maybe that hospitals will say, this is the big systems will start saying it's time to rethink how we get paid. But you're suggesting not, Kim. Well, you're
Can I bring up another consumer thing?
Yeah. Oh yeah. Well, please do. And then.
So we're all waiting for the vaccine, and Operation Warp Speed is going to get it to us, in the year or wver. But
Jared is going to rescue us.
Yeah, something like, what was it, 25-40% of people say that even when the vaccine comes, they're not going to take it. So these are, this is the consumer environment that we're working in. That there is a large number of people who do not respond in health appropriate ways, and that is not going to go away because of COVID.
Roger, I want you to defend all consumers.
That's depressing, Kim. I hadn't seen that. What I was going to say is, I think
it's the whole anti-vaxxers movement on steroids, right?
Yeah. I was going to say that I think that COVID sort of hit so quickly that a lot of healthcare provider organizations, and for that matter, consumers, everyone, had to just react in a hurry. And a lot of them sort of grabbed the nearest thing. Like, well, maybe I can FaceTime my patients on the phone, or I hear Zoom works, or whatever. They just kind of cobbled together whatever they could to make it work. But now I think a lot of them are moving into a phase in which they're being more strategic, and they kind of see that this is not a short thing. It's not changing every day. The question, though, is as they're more strategic, some are probably going to go more toward value-based type, arrangements, and others are going to say, well, strategically, we just need to make up cash in the short term through more of those, fee-for-service model, high-cost events. So I think we'll probably see both. I don't see everybody doing all one thing, but I do see a general change from just grab whatever you need to survive to think more strategically.
So, Brian, I want to drag you in on this one. So Ian Morrison, who was on the gang last week, wrote a piece with THCB, which was his German health minister, his German health minister experience, where he talked to the German, I don't know if you read it, it's pretty funny. He talked to the German health minister, and the health minister was at an interview, and he explained how the employers pay 300% of what Medicare pays in order to keep the providers going. And the German minister said, said something very rude in German, but luckily it wasn't translated. And he suggested, look, this may be time that, okay, the providers want to go back to where they were, or maybe I'm being overly optimistic, saying the system might want to change. But maybe this is the point where we're going to have, the employers, especially the ones who aren't called Amazon or Google and doing well in the current environment, but the people who have restaurants and retail stores and God knows what else, may be ready to make a bigger change here and insist on some of the stuff you've been talking about forever. Is that likely possible? Are you hearing rumblings of that, Brian, or am I being optimistic? That is how Ian was hedging, but he said he might think it might happen. Where are you?
It's certainly what we'd like to see happen. I mean, when it comes, the employers are going to go, the providers and the health plans are going to go, well, it's time to make up for lost time. And they're going to want things to go back to where they were. That the employers are going to go, no way, because we don't have the money. We've got streamlined workforces. We don't have the disposable income anymore. And they're going to push back. What I will tell you is, in the self-insured world, there's an unprecedented volume of companies that are willing to try new things, that are willing to go away from Cigna or Aetna or United and go with Flume Health or some other innovative TPA and do things a different way. I'm seeing groups that together represent 100 or 300,000 lives go and sign up with Carum Health, for example, or the musculoskeletal or the cardiometabolic or whatever it is, and carve all that business out. That shows that there's a appetite for doing it a different way and a willingness to sort of maybe come together and say, no, we're not going to do it the old way. But it could be wishful thinking too. Vince probably has an idea here.
I want to ask you a question. The windfall here, a lot of it's going to employers because patients aren't showing up. And, I think what's the percentage, 50, 60% of payments are through self-employed or self-insured plans. And, some of that windfall goes to health insurance companies, but a lot of it's coming to the employers. How does that affect them? Does that change their attitude, make them more willing? It certainly is putting cash in the employers' pockets.
Honestly, I don't know. I mean, I'm sure you're right. I haven't seen any discussion of it, and I haven't talked to anybody about how it strikes them. They've got to be worried that their patients aren't getting care.
But on the other hand, your point may be right, Vince, but so they may be saving a little bit on their health spend. But
it's hard to tell.
Winter across the board and a bunch of other stuff.
The CFO will be happy, and the
CFO will be happy for that part.
And the VP of HR will probably be concerned about the employees.
But for most employers, right, they're going to see massive decreases in revenue across the board. If you're in one of those industries, if you're in retail, airlines, hotel, travel,
right,
some aspects of manufacturing, across where you haven't been able to put your people to work. That's why Elon Musk was flipping out with the Alameda County health officials, because he wanted to start production because he wanted some cars to sell. So it strikes me as that's going to get lost in the wider point. But eventually, when you come back to the thought about how are we going to deal with self-insured employers, they're going to be fewer people who are working with self-insured employers and getting their insurance that way. There's going to be fewer people, going through those big commercial insurers by definition, because more will be unemployed and be on Medicaid or uninsured or out of the game completely. And then the other thing is, are they prepared to try new stuff enough to push the market around? I think that's the point we're all getting to. And I think we're all kind of, don't want to speak for everyone, but most of us on the gang here are kind of hopeful that's going to be the way it is, because we kind of think that's going to be a better alternative to what we've had before. But it's not clear. And then we just actually great question from the chat from Steve Waddell, who'll be on in the future weeks, and said, is it possible that there's going to be so much deferred care coming back, and people who are sick from COVID that actually don't want to go at risk as a provider, I don't want to be in this world of taking on capitated care. I want to stay in people's service because, if I go at risk for this other stuff and get a guaranteed payment, all this, these sick people will show up. I'm going to be underwater then. I don't know. Maybe another opinion.
Yeah, the market is moving very, very quickly right now, and there's more change than I've ever seen before, and I can be hopeful, but the real question is whether the employers will have the ability to galvanize and mobilize and own the market, because they for sure don't own policy. The healthcare industry owns policy, because the entirety of Congress and the legislatures are on the take. So it's going to be a tug of war.
Okay. So
Yeah,
guys,
I don't think hospitals that have, been the rear guard of COVID, with the intensive cares and the fight against COVID, I don't think it'll be good for the optics if they start crumbling one after the other.
No, I don't. I agree with you, and this is their finest hour. But you also remember that for the last 50 years, they've stuck it to the entire purchasing community in a way that's been unprecedented. And they've done it on the basis primarily of largely of unnecessary care. I mean, the system is built so much on excess now that the healthcare industry depends on it to meet their numbers. And that, I mean, that's not really a point that's up for discussion at all. I mean, that there's lots and lots of data on it.
Yeah.
So like, while I feel their pain and while it's important to have hospitals, the hospitals are campaigning. I was talking to somebody at Florida Blue the other day who said very wealthy hospitals are coming to us and saying, you've got to subsidize us for the short term. And they've got 450 days of operating reserves in the bank. It's hardly the same as the primary care guys who are getting shafted.
Absolutely. And we have 450 days of nothing in the bank at THCB. So. I've already had my All right. I want to flip us around just for the last 10 minutes before we wrap here to talk a bit about the issue that is sort of, coming top of mind in the COVID world, which is opening up. Grace, you started talking about testing. I read Anish's Coca's article on sort of the complexity of testing. I was on a webinar regarding testing from the folks at Everlywell, and seropositiveness and all this other stuff. Does anybody here have a clear idea about whether we have enough understanding of how to do this right? I'm not saying that states will do this right, but if you could say we're going to gradually open up and we're going to sort of test and do contact tracing, Vince raised it earlier. Does anybody here have an understanding that you think that there is sort of general agreement around how to get this right? Or do we think it's the experts, let alone the president and his stuff, are in chaos?
I'll take a stab at that. I think there are at least a dozen countries, and there's a website, I can't think of the name of it, where the virus has been contained. The technical knowledge of how to contain and how to manage this exists. It's a matter of U.S. culture and our inabilities to have our civil rights, or what are perceived as our civil liberties, infringed upon. The technical part we know how to do. Other countries are doing it, have done it.
You have to wear a mask to come on this webinar from now. But I mean, so you're saying we understand. It's just a question of maybe we can't enforce in the US.
Well, who's
So the metaphor that I come back to, I read it in the New York Times. Imagine everybody in the world just stands still for 14 days. The virus dies, and it's all gone. It's not that hard to understand. That's essentially what we'd have to do, and unfortunately the economic side of that is very difficult, but there's enough science in other countries to show that this can be done.
But we've kind
There
of
was an
had
article
that.
in
South
Sci-
Korea, Taiwan are prime examples, even China.
There was an article in Science Magazine just a couple of days ago that indicated that everyone looks, we're talking about the we, everyone talks about R naught, but said that that's not really the important thing. The important thing is the dispersion factor. Article indicated that most people who get COVID don't spread it, but a few people who do spread it are super spreaders. So the trick in figuring out who are the people that have it, who are the people who will spread it? And that, I don't know that anybody has a test for.
Well, A, that, and B, where they've done a good job initially, like in Singapore, they still found an outbreak and they had to go back, they had to go into lockdown. Then the Taiwan,
China's having outbreaks again too.
South Korea, so the New Zealand seem to have cured it, but it's still all over the map. And I don't think anybody has a hand. I mean, you know, I'm a complete amateur. I'm the guy who failed high school biology, so don't ask me for the precise answer. But I did see from Anisha's article and other stuff I read that figuring out, you know, do we know if you're seropositive that you really can't get it again? How many people have to be seropositive to get to the fabled herd immunity? You know, is it going to be okay to open schools and stuff again so we can get back to some semblance of reality in our economy? And so, do you have a theory about this?
Yeah, I'm not terribly optimistic about this testing angle. I think it's one of those, you know, unicorns. Is it unicorn, Wizard of Oz, something like that, that overpromises. Firstly, with South Korea, they actually, we don't know how much of it was testing and how much was it was just aggressive quarantining, how much was it travel restrictions. They do have a they do have a population that's much more supportive of their government, unlike the live free or die libertarians over here. It's not just the libertarians, it's also the New Yorkers that are the issue. But I'm not going to go into the politics.
Hey.
Sorry.
New Jersey girls are different, we know that.
We talk about the testing. The problem with the testing is that you've got a test that if you're negative, there's a very high chance that it's a false negative. And that's the problem. So if you're just going to start quarantining people who are positive, you're going to miss a lot of negative people, and you're going to, and those negative people then can go ahead and spread to other people. So for a start, what do you do differently if the test is positive and negative? If it's the same thing, then that test is not that useful. The second area is this idea of actually identifying communities, those with actually high prevalence of COVID and those with a low prevalence of COVID. And the ones with the low prevalence of COVID, where there are fewer infected people, it means that there are a lot more people that are susceptible. And ones with a higher prevalence means there are fewer people susceptible. So what are you going to do with those two communities? How are you going to partition them? Are you going to say that you two can't, mingle with each other? So even though you can, you know, it's not like toy models that you can just pick one and say, I'm quarantining this. I'm not allowing Philadelphia and Chicago to mingle with each other, but Philadelphia and New York can, because you know they've got the same prevalence level, for example, hypothetically speaking. So acting on the test, I think, is going to be very difficult, and it's going to be particularly difficult given how much the spread is. So there are problems with the limitation of the test, and then there are problems with what you do differently, even with the test results. So I think it's been oversold because it's been something we've never had. So when you think about, you know, who do we blame? It's easier to blame what we don't have than to acknowledge that what we did have was insufficient, or we're dealing with an entity that is far smarter than we are. We can't, of course, admit that because we sent a man to the moon, several of them. So this American exceptionalism, the one thing that's absent was the testing, and therefore the testing became the thing that would have solved all our problems. And I don't believe so. I agree with Anish in his piece.
And when we talk about the test, we have to remember there's a lot of tests out there with varying degrees of accuracy, and there's a variety of ways. We don't have a uniform way of reporting on anything either. Every state is reporting things differently. So we really have no idea what's going on in our country.
Bryce, go to you, and then we're going to wrap.
You know what, we're starting to open up here in New Jersey. Beaches were open, non-essential businesses for curbside are starting to open, hospitals for elective procedures are now starting to schedule that. And everyone's saying this is great, but the scientists, and because of what I do, I'm telling people nothing has changed. There's just room in the ICU for people to now go in. We don't really have data or anything. So it's very anxiety inducing for me because I'm a numbers person. I want to be able to make my decisions on evidence, and we just don't have that. So now I'm wondering, you know what, even the vaccine escalation to do at warp speed, I'm wondering if repurposing a drug or trying to find out from a mechanism of action standpoint, is there a preventative? Is there something else that we can do? Masks, really, hand washing and the social distancing is the best bet that we have right now. And what's happening on social media with the misinformation that's flying around and the polarization, I think that's our most damaging thing as of yet, because we totally blew it on the masks front weeks ago when there was a disagreement that they had any benefit at all. So it's hard ground to try to make up right now. Very frustrating.
I understand if you have an M16 and prepared to carry it around, you don't need to wear a mask because you can shoot the virus as it comes over. Must be true. I've seen it happening in lots of places. All right. So that's the end of our discussion, and then we're going to end the way we always end, which is a quick word for everyone on what they expect to see in the next week or two. So I'll start with you, Kim. Next week.
Well, as Grace was saying that we've opened up almost everything, most places, and I don't think most places are ready to do it. So now we're just watching how quickly that tail catches up with us and how big the impact's going to be.
Okay, a spike coming up. Brian, next week.
I'm with Kim. I think that's exactly what we're going to see, and it'll be a political football. Yeah.
So Rob, what do you expect to see in the space in the next week?
Well, I can tell you what I'm hoping to see. I'm hoping to see a few barber shops opening, and masked barbers cutting hair of masked people, and I think that would be. I guess you can't have a shave at the same time, but at least the haircut. I think that would be a significant step in pseudo normalizing things, step in the right direction. It's even more important than restaurants opening.
Grace, next week.
I want to see more concrete guidance for the general public on how to now safely engage. So the CDC released a report on guidance on how to open up, but how do we, who've been sheltering in place for 10 weeks now, go back in and have concrete information and guidance on what's a low risk, what's medium risk, what's high risk? How do we start engaging with our families and parents, the elderly? What stores, what kind of common day things, going to the barber shop? How do I do that safely? Is it with a mask and with a face shield?
You're hoping for a clear guidance from the CDC and the federal government. Good luck on that one.
No, I didn't say from the CDC and the federal government. I didn't say that. I just need we have enough expertise to be able to put something together.
Maybe Andy Slavitt's Twitter feed will tell us the answer. Vince.
Hey, I'm going to take a sec to substantiate my earlier claim. The website to go to is called endcoronavirus.org, and scroll down, see a list of countries, and click that link. It's ranked yellow or green, red, yellow, and what you see is 40 plus countries that have successfully flattened the curve, and they're green, and you see US in red. Sarab used the word American exceptionalism. I think we as Americans have a lot of humble pie to be eating. We're not doing a very good job compared to other countries in the world.
So next week we're gonna get from the red to the green. Any chance it's getting to the orange?
I think it depends on whether or not President Trump wears a mask today.
Is he supposed to be going to Ford? And
he's going to Ford, yeah.
And he said he has to wear a mask. We'll see what happens. Pence didn't want to wear one at the Mayo Clinic, and the Mayo Clinic was too cowardly to force him to do so. Anyway, Devin, next couple of weeks, what are you looking for?
I think it's still early, actually. I don't think we'll see data in a week that will indicate that the opening up was a bad idea. I think it'll take a while, and it may actually not bounce back in the way that we thought, given the sort of summer virus lull. that is fairly common, as I understand. I'm MPH, not MD, but my understanding is viruses don't like heat. And as we start to heat up in our summer, we may be thinking that we've got this thing licked for quite some time before we realize that, in fact, we don't. But it's not going to be a 1 to 2 week thing. It'll be a while. I think in the next couple of weeks, it will be interesting to see how more jurisdictions start to look at enhancing their existing contact tracing efforts, which are happening in lots of places without technology, with technology, now that more of it's being made available.
Well, Gia, thanks so much for joining us on the gang today. Great having you here. Your prediction for the next week or two?
Thank you for inviting me. It was a lot of fun to see some old friends and make some new ones. We have a holiday. Memorial Day is coming up. That's traditionally a fairly social time. I think that I expect to see more spread in how different states and jurisdictions are handling all this. And it'll become really interesting to watch the difference between those who are super lax and those who are super controlled. So it's just to speed it all up.
Super American exceptionalism on the way. So my forecast for the week is that we're going to really find out a lot more about what kind of at-home testing from who works well, is available, and whether Everly Will is involved. We're going to see the Abbott home testing thing. There's some discussion about that in the UK at the moment, and who's delivering that. And then, of course, we have the big giant of Amazon talking about where they're going to get involved in COVID, delivering tests to the home. And I think how we think about testing, whether or not, as Saurabh says, it matters or not, is going to change dramatically over the next few weeks and months. And you're just going to see the first things of that as the first home test has now been approved. So with that, I want to say thanks to all of my team on the gang here today. Today we had Kim Bellard, Grace Cordovano, Saurabh Jar, Road Rag, Brian Clever on the employer front from Charlotte, Vince Gordis from the wilds of Idaho, Devin McGraw from Holt up there in Silicon Valley, and our guest, Lajir Ricciardi. I nearly got your name wrong, but I got it right, Lajir Ricciardi. And that's it. Next week, we'll be back, same time, same place, 1 p.m. Pacific, 4 p.m. Eastern on Thursday the 28th. We'll have a couple of special guests. Look forward to seeing you all then.